Dr. Christy Anderson will be introducing our presenter today.
Thanks, Rhonda. Appreciate it. Yeah, I'm really excited. I've been looking forward to this presentation for a while. It's an important one. The subject is of value because I think while clinicians definitely recognize the importance and necessity of cancer screening, explaining the nuances of cancer screening to patients is significantly more challenging. When we talk to our patients, it's often clear that many do not understand the difference between screening and diagnostic testing, and most are unaware of other components of the screening process to include the meaning of the U.S. Preventative Services Task Force grade recommendations, the probable reasons for the discrepancies that exist between professional medical guidance organizations, and the potential risks of screening, such as overdiagnosis of clinically irrelevant tumors. And all of these factors create frustration and confusion, and it deems the concept of shared decision-making vital to informed consent and assuring our patients optimize healthcare decisions in accordance with their values, their personal values and goals. Prostate cancer is an excellent example that highlights some of the aforementioned challenges I brought up, and also the nuances, including the disagreements from reputable clinical associations about the overall utility of prostate cancer screening. The U.S. Preventative Services Task Force grade A and B recommendations do not recommend prostate cancer screening at this time, and thus it is not covered by the program. So with that overarching complexity, I'm really happy to introduce our speaker today, who is discussing research aimed at helping healthcare professionals better understand and adopt shared decision-making in the setting of prostate cancer screening. Dr. Michael Diefenbach is a professor of medicine, psychiatry, and neurology at the Zucker School of Medicine at Hofstra University and the Feinstein Institutes at Northwell Health in New York. He is also associate director of the Institute for Health System Science and director of behavioral research in the departments of medicine and neurology. He has a long history of service to the behavioral medicine and academic community. Past activities include tenure as a senior associate editor of the journal Translational Behavioral Medicine, as well as serving as the president of the Society for Behavioral Medicine. He is also the primary author of the recently published Handbook of Health Decision Science. For the past 25 years, his research has focused on exploring psychosocial issues among prostate, bladder, and breast cancer patients. This has included the assessment of cognitive and affective factors in reaction to disease and treatment, their influence on treatment decision-making, and the exploration of quality of life. We are really happy to have you here. Looking forward to your presentation.
Thank you very much. Thank you for the kind introduction and welcome everybody. And I would also like to mention my collaborator and co-investigator on this award, Dr. Jacqueline Moline, who is the professor and chair and senior vice president of the Department of Occupational Medicine, Epidemiology and Prevention at Northwell Health. And of course, I would also like to acknowledge the funding that we received from the CDC through this UO1 grant award that made this research possible. So let me tell you a little bit what we're going to do and what I will be talking to you about this afternoon. I want to tell you about how we developed the shared decision-making and informed decision-making paradigm for the Northwell World Trade Center Health Program, and through the development of a decisional screening booklet. I will tell you a little bit about the methods that we have developed to revise and adapt this booklet, and how we integrated that into the busy clinic. We'll also mention how we trained healthcare providers in shared decision-making. And then I will tell you a little bit about the in-clinic recruitment procedures, and then the COVID-19 related curveball that we experienced and all of us experienced that hampered our recruitment. Then I will talk about the research results, probably the most important part that you're looking forward to, and then some of the lessons learned from this effort. So, as you all know, first responders suffer from high levels of physical and psychiatric comorbidities. On the psychological side, you have elevated levels of post-traumatic stress disorder, elevated levels of depression, anxiety, and more frequent panic attacks. And on the physical side, we have a lot of respiratory problems involving COPD and sleep apnea problems. We have problems with asthma, acid reflux, GERD, and we also have recently an elevated level of cancer incidence. So as of September 2022, the number of members in the World Trade Center Health Program are 84,289 responders and 35,958 survivors. And of those, 23% receive care for cancer. About 2,000 members have died from cancer. And the top 3 cancers that are reported are prostate cancer number 2, and then skin, non-melanoma and melanoma-related skin cancers. As a comparison, these numbers are, if you compare them to the top 3 male cancers, as taken from the American Cancer Society's Facts and Figures from 2022, the number 1 diagnosed cancer is prostate cancer, followed by lung and bronchus, and colon and rectal cancer. So you see that prostate cancer is really an important cancer for the responders and for our population. So, despite an elevated risk of prostate cancer among those members, screening for prostate cancer is not offered, as Dr. Anderson just mentioned in the introduction. It's not currently. The USPTF has revised their recommendation a little bit, but nevertheless, prostate cancer screening is a complex decision. So why is it so complex? Well, the PSA test is not the most accurate measure of underlying prostate cancer. So if a man has a blood test to measure the PSA levels, it is often, and it is elevated, and it is elevated around the borderline of 4 or so, 4 or 5, then it is oftentimes repeated. And then if it stays elevated, it is followed by either a biopsy or an MRI. So this alone makes some complex decision making, because you don't get a straightforward answer from this blood test. Then you're dealing with cancer, and cancer is, of course, a scary proposition for anybody, and particularly for men who have a history of psychological or psychiatric morbidity. So whatever we do in terms of introducing a screening procedure, we have to do this in a sensitive manner that takes the unique conditions of the screen population into account. So if you apply this to our first responders and survivors, you really have to make sure that you don't distress the population that you want to screen, and you want to make sure that patients are optimally informed and make a decision that is right for them. And usually what professional organizations such as the American Neurological Association or the American Cancer Society suggest is that we at least have to achieve an informed decision making, and better even a shared decision making. But what are the differences between the two? So informed decision making is defined as, and this is has been the standard for a long time. It's defined as that patients receive sufficient information about the risks, the benefits, the limitations, alternatives, and uncertainties of clinical condition to make a value concordant decision. What does value concordant decision mean? It is something that is, you make a decision that achieves a future state that is important to the patient. So if the value is cancer control, for example, then you make a decision that is likely to ensure cancer control. If it is quality of life, then you might do a favor decision that skews towards quality of life. For a screening or for treatment decision making, these are oftentimes the tension points. And oftentimes informed decision making is achieved with decision aids. And the decision aids can take on different kinds of forms. They're either brochures or they are interactive kinds of tools. They are web-based or software-based, and those have been around for quite some time. So what does shared decision-making is? Well, informed decision-making translates into shared decision-making by including a provider. And the provider helps the patient understand the benefits, the harms, and the uncertainties of the available options. And most importantly, they provide a forum for asking and answering questions between the patient and the healthcare provider, and it's a mutually agreeable, beneficial situation, ideally. And the goal is that this exchange of information has a goal to clarify the values of the patient, so that they then derive to this value concordant decision. So that's where we're at. So we're having a situation of informed decision making and shared decision making. So our study was conducted at the Northwell World Trade Center Health Program, which is situated in Queens, New York. It's one of 7 clinical centers of excellence in the New York, New Jersey area. And it provides medical monitoring, diagnostic, and treatment services for the World Trade Center community. And in 2018, when we started the study, there were about 3,000 patients seen every year. 90% of those patients were male, and only about 132 were younger than 40, and 40 was our cutoff point for prostate cancer screening. Now, the recommendations are oftentimes that you are screening at 50 or older, but then again, it depends on whether you have a history of prostate cancer or whether you are of African American descent, who African Americans, as you probably know, are of an elevated risk for the diagnosis of prostate cancer. The clinical staff at the Northwell Health Program, WTC program, consists of physicians, nurse practitioners, psychologists, social workers, medical assistants, nurse managers, office coordinators, and the director. It's truly a multidisciplinary team of experts who provide care and social support to these almost 3,000 patients every year. So our study aims were to adapt a stepped decision-making approach for prostate cancer. And I will explain to you what we mean with the stepped decision-making approach for the members of the World Trade Center Health Program. And we also, the second part of this aim one was to train physicians in shared decision-making, or SDM for short. And the second part, after this developmental phase and testing was achieved, we want to implement that step decision-making approach into the clinic, and with the goal to identify how many patients are willing to be screened, how many patients are saying, no, I don't want to be screened, how many already had been screened from at other places outside. Are there any psychosocial or demographic factors affecting this patient screening decision? And what are the psychological and clinical outcomes of accepting or rejecting prostate cancer screening? All right, so this is what we thought we would do with our how we would implement the study. And we worked very closely with the clinic staff. Nothing could happen without the cooperation of the healthcare providers and the nurses and everybody else involved in the clinic. So we had a number of meetings to figure out what is the best way of implementing this. And this was also one of the reasons why we decided to create a booklet, because we knew that patients will be receiving mailings in anticipation of their annual visit. So a booklet, sliding in a booklet was feasible and acceptable. And it also and we learned this later, it also ensured that patients were actually looking at the booklet, and we did not need to send them to another website. So they received the booklet and the consent form and a lot of other clinic documents that are part of their regular annual visit. Then at the clinic, they meet with a research assistant or a navigator, as we called them, and the patients gave consent. And this was not the first time that they heard from the navigator, because the navigator called them beforehand and asked them whether they were interested in the study. And if they said yes, then we asked them to come in a little bit earlier. And then we did this whole consent and baseline assessment process. And then we asked them whether they had any questions about the booklet, whether they looked at the booklet, and whether they made a decision about screening or not screening. And then the patient decided whether and there were basically 3 different kinds of decisions possible. They could say, I want to get screened, I don't want to get screened, or I want to get more information. And this more information is this shared decision-making paradigm that was then triggered. We had two different developmental phases. One was this selecting a brochure and adapting the brochure, and then training providers in shared decision making. Let's talk about the brochure development first. So we looked at the literature for available prostate cancer screening booklets, and we found the one that was done by the American Cancer Society as most appropriate. It had easy to understand information, and it laid out the pros and cons very easily. So we then decided that we need to involve all of our patients and stakeholders in this process, in this adaptation process. So we conducted several focus groups with members, and we showed them the booklet, and we asked them a couple of questions about the booklet, and then we asked them what they would like to see differently. And then we reviewed and adapted the booklet, called them back, and presented them with the booklet, and then they provided final feedback. We incorporated that, and that was the final product. So with these focus groups, we had focus groups were even pre-COVID were a little bit of a challenge. We called many patients, and they said they would show up, and then they didn't. So we had 9 patients over 4 focus groups in September and October of 2018, and we asked them about 2 different kinds of areas of interest. First of all, we wanted to know from them how much do they know about prostate cancer screening, and how much do they know about prostate cancer treatment, and whether they had that already, and or whether they were screened already, and whether they are for screening or against screening, or what are their beliefs and expectations around screening. So patients reported to us that they knew that there were some uncertainty about PSA test results. They provided many anecdotes from family members and or neighbors who were tested and then had a false positive, or were then that they had to go through a lot of different kinds of subsequent examinations. They also mentioned that there was a digital rectal exam, which they were not thrilled about, and that was an issue that they did not want to engage in. A lot of patients, the majority were familiar with the treatment for prostate cancer, surgery or radiation, but they also didn't know how to start the conversation with the provider about screening. How should they ask about it, and was it something that they could ask about, and so on. So then we gave them the screening brochure, and when they looked it over, they gave us these 6 points that they wanted to see changed. So one is that they were most interested in how is prostate cancer important to them, And how does that, they were not as happy with these general kinds of information that was provided. They want to have it more tailored to them. They also didn't like the illustrations that were included. They wanted to, again, have more targeted illustrations. So targeting meaning men that looked like them. They thought that the existing information was approachable, but they wanted more specific information, especially of what to expect after they were done with screening, because that was one of the aspects that were missing from that book. They said, well, we also would like to see what other men were thinking about it. So they suggested testimonials, although they didn't call it that. They wanted an FAQ section. And some statistics. The ACS booklets had none, probably because for health literacy reasons, but our men asked for it. And they wanted they wanted to engage in a conversation with the physician. So this is what so we did basically everything that they asked us to do. This is the title page of our booklet. You see that we have included pictures of men that looked like our patient population. They represent different ethnicities and racial backgrounds. We described the prostate cancer and the PSA test in more detail. We emphasized the risk of prostate cancer to our target population. We included the patient perspectives, and we included also a doctor character to answer frequently answered questions. We listed the pros and cons of getting screened. We gave a flow chart of what to expect, and we asked them at the end to decide and indicate what they wanted to do. So here you see we added two different perspectives of two men. We called them Doug and Richard, and we compiled them. We gave them fictional stories that were culled from some of the responses from our focus group members. So these were some of those testimonials that patients were asked upon. We wrote everything for a low health literate population and at the 6th grade reading level. We also included Dr. L, and he gave some perspectives and corrected with his comments, with his little blurbs there. Here for this one, he tried to correct misconceptions that patients have. So here, for example, hi, I'm Dr. L, experiencing one or more of these symptoms. These here listed above does not necessarily mean you have prostate cancer. So again, this is patients ask, how do I know that I have prostate cancer? And we list some of those things, but then we also say that doesn't necessarily mean that you have it. And then this was a page of the pros and cons of receiving prostate cancer, and patients were asked to check off here the things that are important to them, and then just they can discuss those reasons, but just listing them out that's part of that value clarification process that I mentioned beforehand. So this is important for them so that they can really think about what it is. What are the consequences, and does that really, is that something that is important for me or not? And then here is the flow chart that patients are, that asks them what actually will happen. So we have this little traffic light approach. Green is clear, red is they might have to see a specialist to do something else. So this is sort of the usual flow, and patients thought that was really helpful to them. And then here are the two testimonials, or from the two different kinds of options. And we presented both of them because we don't want to convince patients to do something that they shouldn't do. It is really their decision. So here is verbalized the pro position and the con decision for them. So that was, and then here at the end, is here they can actually indicate what they want to do. Yes, I'd like to be screened. No, I don't want to be screened, or I need more information. And if they put an X right here, then this triggers the shared decision-making protocol. And then our navigator, our research assistant navigator, conveyed that decision to the physician. It was part of their chart, and the physician then could, if I see an X here, I need more information. After at the appropriate point in time, they can then say, okay, Mr. Smith, I hear you need some more information about prostate cancer. What are your concerns? Or screening, what are your concerns? What would you like to know about? And then they engaged in that kind of shared decision-making task. So what did we do within the clinic? Well, we trained the healthcare providers in shared decision making, and this was a separate process that took up about an hour and a half or 2 hours. The first was a meeting with all of the staff where we introduced the study and solicit their information and their knowledge about shared decision making. And I gave an overview of all of the different elements of shared decision making. And then in the second part, we broke out into pairs, and they took turns in role playing the physician, a very familiar role, or the patient, and they could role play of that decision making process. And the healthcare provider, took to it and really enjoyed that part, and said that it was really helpful, and everybody appreciated this review of principles and the little practice that we provided. So for the rest of the preparation and the rest of the logistics that we had, we printed all of our booklets and we dropped them off, and the clinic staff was kind enough to slide it with all of the other things in the envelope that was mailed out about 3 to 4 weeks prior to their appointment. Then our navigator / study coordinator screened the schedule, the patient schedule, and reached out to all of the patients scheduled to come in for their annual monitoring visit about 2 weeks beforehand. He solicited interest and confirmed that they received the booklet, meaning also, remember there is a booklet in there, please take a minute to look at it. We will be talking about it because it deals with prostate cancer screening, and you might be asked, or you will be asked, whether you want to be screened or not, and this is some appropriate information for it. And then the patients came in. They were asked to come in a little bit earlier. They signed the informed consent. They confirmed that they've read the booklet. Most of them have. If some didn't read the booklet, they had some time to go over it then and there. Then we administered a short baseline survey, and then we asked them about the screening decision. So basically, you want to be screened? Yes, no, or do you need more information? The navigator conveyed the decision to the provider, and then very importantly, 3 to 7 days after that, there was a telephone follow-up to assess any decisional outcomes and emotional outcomes of the screening process. So then we were chugging along. It worked out really nicely with recruitment. We had good numbers. I'll show you them in a second. And then from March to August in 2020, the clinic did not see any patients in person. Partially, the office was used for COVID testing, and then they went hybrid in September 2020. So a mixture between in-person and telehealth procedures. That, of course, impacted our recruitment procedures. So prior to COVID, there was a paper consent. Patients completed the baseline, as I said. There was the clinic staff collected the blood for the PSA test for those patients who consented to it. And we gave a financial incentive in form of a Clin card in person. During COVID, we called them just as before, but patients had to complete the baseline measures on their own. There was nobody there to answer questions if they had any. We had to outsource the collection of blood for the PSA test. We engaged and found a Northwell affiliated service called LabFly, who sent by a person to take the blood sample. The consent was electronic remote. We mailed the financial incentives. There was lots of back and forth, but the most important thing, which was the most difficult part, was that there was a lot of lag time between we called them, solicit patient interest. Did you get your packet? Yes, I got. Please sign this. We need to wait until we got the signature back. Then we had to wait for the baseline survey to go back. So there was a lot of different kinds of telephone and emails that going back and forth, and it was just logistically much more difficult. And then, so these are the study and enrollment numbers. Of all of the men who we reached and who expressed interest, that was 83% of all eligible patients. So we called them and we asked them, are you interested? 83% says yes. And then everybody who expressed interest and came later, we then enrolled. So post onset of COVID, we only reached 16% of eligible patients. They were not as interested in it. We got a lot of no's. And then even when they said yes, they were interested, we were only able to convert 23% of those patients. So our recruitment really dropped off during COVID considerably. But nevertheless, we were able to enroll 666 patients. So we assessed for eligibility 1,947. We had to exclude 1,281 patients. 213 didn't meet exclusion criteria. 386 declined to participate. And the not meeting inclusion criteria, those were patients who oftentimes had already had prostate tests. And this was one of our inclusion criteria, that they have never had a test before. And then of those, and we had 682 we were unable to reach. So we enrolled 666 patients. And now of those, informed decision-making were 659, and only 7 patients wanted to speak to a physician and needed more information. Of those who decided, of those 659, 99% or 650 decided to be screened, and only 9 declined not to be screened after reading the booklet. And for the shared decision-making, they wanted to have more information. Of those 7, 6 men decided not to be screened, and 1 decided to be screened after they get more information. And then, of course, this was followed by the 3 to 7 day telephone follow-up. So here's some demographic information. Mean age was 55 years old. There was no difference among men according to race. They were either unemployed or retired, which is also to be expected for this patient information. Our study population was fairly well educated. I mean, some had college or university, had a bachelor's degree, and a lot of people had at least a high school degree. And so this is the decision breakdown again, with some follow-up information in terms of cancer control. So as I said, we had 659 informed decision-making, 7 had shared decision-making, yes to screening 650, no to screening 9. Of those 650, 40 had an elevated PSA, and of those 40 with an elevated PSA, 8 were diagnosed with prostate cancer. And here, of course, we don't have that follow-up information. This one person turned out to had a normal PSA. So we had a fairly, I would say, normal distribution in terms of elevated PSA and prostate cancer detection after this elevated PSA. So what are some of the PRO results, the patient-reported outcomes? We were all concerned, as I mentioned to you at the beginning, whether patients were would be taking this, talking about prostate cancer screening, about cancer in general, whether that had some adverse psychological reaction, and was that screening process, had that any adverse effects? And I'm happy to say that it didn't have it. So that was good. The patients came into the clinic with very low levels of anxiety. And that anxiety 3 to 4 days later, or within that follow-up period, was decreased even further. They came in with the decision, and a lot of them, as you know, have made a decision based on looking through the booklet. Their satisfaction with their decision was pretty high. This is from a 1 to 5 decision scale. And then after 3 to 4 days later, or a week later, that decision improved a little bit. I mean, these differences are not significant. And then the satisfaction with the booklet was equally high. They liked it to begin with, and then reflecting on it on the follow-up call, they still liked it. So they were overall satisfied with the entire process. They were satisfied with their decision. It was not anxiety provoking for them, which was very gratifying for us. So to conclude, what are some of the lessons that we have learned? We successfully informed patients about prostate cancer screening and the different kinds of options. Because we used our stakeholders' input, both from the patient and from the provider side, we successfully integrated the program into this quite busy clinic. We also prevailed in a low-tech approach through the booklet. So we did not use the latest shiny electronic toy to inform our patients, but we had an old-fashioned booklet. But we put a lot of time and thought and effort in making this booklet really what patients wanted. And our results show that we succeeded in that. Preparing patients to make a decision was successful through this booklet. Only 7 patients really were triggered for the shared decision making. However, we needed to have this navigator, this research assistant in the clinic. Without that person, it would have been really hard to do this. We needed somebody to make sure that the information was assessed. We needed somebody to make sure that patients really looked at the booklet, that somebody was there who was at least available to answer some question or to remind them that, hey, remember that booklet? Oh yeah, I remember that booklet. Yeah, so what do you think about, kind of thing? And then that interaction, I think, contributed to make this what could have been potentially a more stressful situation, a really low stress and low anxiety situation, resulting in high decisional satisfaction. And those low levels of distress and high satisfaction persisted beyond the clinic. So it was not just something that they came in with and then didn't want to mention this before, but it was 7 days later they confirmed this. What we also learned that it's necessary to involve all stakeholders. As I repeatedly mentioned before, you cannot do this program without the input of the patients and the physicians. And the navigator is when you look at it from a cost perspective, it's another person in the clinic, and that means it's a fairly high touch intervention. It's not automatic, but these things are usually by design not automatic. If you want to have these good results, then you have to there needs to be support for this there. So can we use this model with other cancers or with other conditions? Dr. Moline suggested that we could use this for screening for thyroid cancer that has a number of pros and cons, and that is also elevated. But there are a number of different kinds of decisions that patients are facing, and we have applied the shared decision making and in other areas, usually to at a satisfactory progress. What was nice and gratifying to see was that patients really took to the pamphlet, and they read it and they felt it was interesting for them and it provided information. This was in contrast to some of the less high-tech information provision that we have used in other studies, where uptake of standalone programs where patients are directed to it, but not really they are prompted, but not have less of a hand-holding to really engage with the product. We have a much lower uptake and engagement. So this was really much better. So I think this is as I said, the take-home message is you can do this in the clinic, but it takes some effort and some preparation, and you need to have adequate support within the clinic. I want to thank everybody for listening. I want to thank you for joining this program. All of our participants I would like to thank. This amazingly supportive clinic personnel. Without them, we couldn't have done this. And then, of course, the research team, especially Thomas Bistretta here, who single-handedly contacted all of the people and interacted with them. And then, and now I'm open for any questions you might have. Thank you.
Dr. Diefenbach, thank you so much for that presentation. It was fantastic. And I think there's a lot that we can pull from this for other health conditions as well. So I did already receive a message in the chat box. So we're going to go to Dr. Moline, since she participated in this, and then we'll turn it over in just a moment to that question I got in the chat box. So Dr. Moline.
Thank you, Rhonda. Michael, it was phenomenal. You know what, I think there are a couple take homes from this project that really stuck out to me. One, you need to be in person to be able to do this kind of work to really get good results. And COVID has taught us how patient recruitment can be affected by that. But when we think back to what we started at the initial part of the project in terms of the pamphlet and the materials to how we ended up, we really got the input of our patients. Mm-hmm. And I think that led to the success in the pre-COVID time, where you saw that everyone agreed to participate. They all had the materials, they all had the chance to read them. And I think that does, we ask a lot of our patients to participate in various research projects, because everyone's coming up with great research projects that we get to hear about every month. But we often don't include them in how we should structure them. So I think this can be illustrative of how it can really improve uptake in a study. I think it's also, as we move more in medicine towards greater patient participation in decision making, where they feel like they have an opportunity to make a decision rather than being told what they should do. I think that particularly with screening or in areas where there is uncertainty, to give them pros and cons and allow them to come with you and make a decision that will benefit their health. I mean, I just think that it's a model that we can use. And the reason that I talked about thyroid or any of the other screening tests that we do is, you know, as Dr. Hall raised in the chat, that there is a lot more data now coming out about PSA and whether it's useful or not for screening, and or is it better in targeted populations. Obviously, our hands are tied a little bit by the USPSTF and what we're allowed to do as a federally funded program. But and those are the rules and regulations that we have to abide by, understood. But there, you know, the question is, can there be carve-outs for areas where we know that our patients are at increased risk? And what should we be doing about things like thyroid, where again, screening has never been shown to be effective, yet we know that thyroid cancer is more common in World Trade Center responders. So that's something that I think we need to think about going forward. Similar to prostate cancer, it is elevated. So great talk. This has been a really great project. It's been great for our clinic to involve our patients. They really enjoyed it. We actually identified some cancers, which was always not good, but good in the sense that we identified some cancers, not that they have them. And anyway, I'm going to stop now.
Thank you. Yeah, I think I agree. I think the patient input, and I mean they're called stakeholders, right? And stakeholders because they have that stake that they have in this process then translates over. Even though we only had a small group in the focus groups, it reflected in the product, and we have reminded patients that the booklet was designed by them for them. So I think that is very important.